Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we are going to be talking about a targeted approach to non-segmental vitiligo treatment. Our moderator this evening is Dr. Leon Kircik. Dr. Kircik is president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences. Our speaker this evening is world-renowned Dr. Pearl Grimes. Dr. Grimes is director of the Vitiligo and Pigmentation Institute of Southern California, clinical professor, Division of Dermatology at the David Geffen School of Medicine, University of California, Los Angeles, California. We'd like to thank our supporter, Incyte, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to it using the phone audio in the audio pane on the right-hand side of your screen. If you're having technical issues or if you'd like to submit a question to our faculty, please submit the question in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We'd greatly appreciate it if you could fill it in and send it back to us. Again, if you want to submit a question, use the question chat pane on the right-hand side of your screen, and I typed a note there so you could see where you needed to type in your questions. So without further ado, I'm going to pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Thank you for joining us for another educational series of International Dermatology Education Foundation. As you may know, we are a nonprofit organization, and our mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Also, as you may remember, we have been all around the world globally as well as nationally. We have been up in Canada, we have been down in South America as well as Asia and Europe in the past, in the hopes of improving dermatologic education and awareness among peers and among the public. Tonight, we are very, very lucky to have my dear friend and what I call her the queen of pigmentary disorders, both nationally and globally, Dr. Pearl Grimes from Los Angeles Vitiligo and Pigmentation Institute of Southern California. She is a clinical professor at Division of Dermatology, Dr. David Geffen School of Medicine, and we are very lucky to have her tonight to talk for us. Thank you, Pearl, and welcome. Please take it over.
Leon, it is truly my honor and pleasure to join you tonight, and I love working with Leon, and I want to say a major hello to everyone on the webinar tonight. So we're going to talk about the first targeted approach for treating vitiligo. You know, something wonderful happened last summer, and that is Opzelura was approved by the FDA. And as I mentioned, this became the first and only FDA-approved medication for treatment of non-segmental vitiligo in the adult and pediatric population, 12 years of age and older. And I want to share the data with you this evening. So this is a promotional presentation. It is sponsored by the Incyte Corporation. I am being compensated for the lecture this evening. The information being presented by me this evening is consistent with the FDA guidelines and US FDA approved labeling for Opzelura. I can only answer questions that are on label this evening. We will cover important safety information during this presentation, and full prescribing information for Opzelura is available with this presentation as well. So let's begin by talking about indications and usage. As I mentioned, Opzelura is indicated for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. It was also approved for use for the topical short-term and non-continuous treatment of chronic use in patients with mild to moderate atopic dermatitis in non-immunocompromised adult and pediatric patients 12 years of age and older who had not responded to other topical modalities. Use of Opzelura in combination with therapeutic biologics, other JAK inhibitors, immunosuppressants is not recommended. We're going to spend a significant amount of time this evening covering important safety information. We're going to talk about serious infections leading to hospitalizations, death, including tuberculosis, bacterial, viral infections. We're going to cover higher rates of all-cause mortality associated with the JAK inhibitors. Later in the presentation, we'll talk about lymphomas, other malignancies. We'll talk about MACE, which stands for major adverse cardiovascular events, as well as thromboembolic events associated with JAK inhibitors. So with that background, now let's take a deep dive into our data. Let's talk about vitiligo. First, talking about vitiligo as an autoimmune disease, the burden of disease, and vitiligo management. So vitiligo is a rather classic autoimmune disease. It is associated with the interplay of patients having a genetic predisposition that is often brought on by some environmental trigger. Many of the genes that are associated with vitiligo are what we call immune susceptibility genes. And these are the genes that immune susceptibility genes are probably the key players in at least 90% of patients. We know that 25 to 50% of patients with vitiligo will have a first or second degree relative with the condition, and 6% of patients with vitiligo will have a sibling with the disease. However, this genetic predisposition may never unmask itself without some potential trigger. So what are these triggers? These triggers can be a sunburn. It can be some form of physical trauma. It can be a chemical exposure. For instance, we know that in someone who may be immunogenetically predisposed, hair dyes may trigger vitiligo. And there is significant stress data now suggesting that psychological stress, which can alter the immune response, can also be a trigger for vitiligo. Now, if we go globally, vitiligo, no doubt, is the most common depigmenting skin disorder that we see around the world. In the United States, vitiligo has been reported to affect up to 2.8 million adults living in the United States. And if you look at when individuals develop this condition, the current databases suggest that 50% of patients will develop vitiligo by age 20. But I will tell you, we're seeing a really interesting observation, and that is we're seeing far more patients who develop late onset vitiligo after age 50. I think it's also important for everyone on the call to recognize that vitiligo is associated with comorbid autoimmune disorders. The most common comorbid autoimmune conditions related to vitiligo, the thyroid disorders. Of the thyroid conditions, Hashimoto's thyroiditis is probably number one. Some of the other associated comorbid conditions include alopecia areata, type 1 diabetes, rheumatoid arthritis. So here at the Institute, we perform baseline laboratory testing on all of our new patients because of that strong association with other comorbid autoimmune diseases. I think another very important take-home message is if you look at who gets vitiligo, there is this myth that vitiligo is much more common in very dark-skinned individuals, particularly African Americans. And that's truly a myth. The darker the skin, the greater the visibility of the disorder. And our current data suggests that vitiligo has an equal incidence in all racial ethnic groups. Now, how do we classify it? So it's classified based on two major clinical phenotypes. So our big classification, we classify the disease as non-segmental vitiligo and segmental. The overwhelming majority of patients who have vitiligo fall in the non-segmental vitiligo bucket. The characteristics of non-segmental vitiligo, it can progress slowly or rapidly, and this is the type that's unpredictable. It may be stable one day and may spread rapidly the next day, and that's one of the traumas associated with with non-segmental involvement. Subcategories for non-segmental include acrofacial involvement, where we see it on the face, distal extremities, universal or very extensive disease, and then focal involvement, but very often that focal patch will progress to one of the other categories. In contrast, the minority of patients have segmental vitiligo, common onset in childhood. It's probably less than 20%. The unique features of segmental vitiligo, it'll spread for a year or two, and then it stabilizes and doesn't progress anymore. And the majority of these patients don't go on to get non-segmental involvement. Keep in mind, and while sometimes segmental can be difficult to treat, it's most responsive to autologous grafting procedures. And in our clinical trials, Opzelura was only approved, we only enrolled patients who had non-segmental involvement. So if we look at vitiligo based on the variability of repigmentation, we know that some areas respond much faster than others, and these are usually areas with a higher density. We get our very best repigmentation responses on the face and the neck, areas that are higher in hair follicle density, chest, arms, forearms, abdomen, and legs. But of these areas, very best responses on the face and the neck. Areas that repigment more slowly, areas that have a lower hair follicle density, the feet, the fingers, backs of the hands. These are traditionally areas that we struggle with, and areas that may not repigment at all, palms, soles. We struggle with genital areas, particularly in men. In my experience, genital areas in women respond much better, and mucosal surfaces. And if you have an area with terminal white hairs, which suggests that you've lost that reservoir of melanocytes in the outer root sheet of the hair follicle, those areas are much less likely to repigment. Now, if we look at where we stand before where we have historically stood, as I mentioned earlier, up until last summer, we had no FDA-approved medications for vitiligo repigmentation. What tools were in our toolbox? What did we rely on? The tools for me, topical steroids, the topical calcineurin inhibitors, tacrolimus and pimecrolimus, oral corticosteroids for stabilization, narrowband UVB, which I cannot, it's essential for what I do on a day-to-day basis, and surgical procedures that we use for autologous grafting in patients who have limited involvement. So at this point during the lecture, what are the key take-home points? We've talked about vitiligo being an autoimmune disease associated with comorbid autoimmune conditions. It affects every racial ethnic group. We have no data suggesting it's more common in one group versus another. Non-segmental is the most common type of vitiligo. Those are the patients that we treated in the clinical trial. In response to treatment, there is a variation depending on the anatomic site, hair-bearing areas, best responses, face, neck, most recalcitrant areas, hands, feet, and there's clearly a dire need for new treatments for this psychologically devastating disease. Now, with that, I now want to talk about mechanisms of the pathophysiology of vitiligo and how Opzelura works and its mechanism of action. So if we look at what is driving depigmentation in vitiligo, there's a cast of players. Who are the players? They're melanocytes, they're autoreactive lymphocytes, they're keratinocytes, there's gamma interferon, and they're chemokines. And these are the players that we're going to talk about. So what happens first? There's a triggering event within a melanocyte, oxidative stress. So what are the triggers for oxidative stress? It can be chemicals, UV radiation, other forms of injury. So that triggers oxidative stress. We think that oxidative stress is the trigger for immune activation and the production of these activated CD8 lymphocytes or autoreactive CD8 lymphocytes that migrate into the skin. And so what happens here is these cells migrate into the skin. They release gamma interferon. When they release gamma interferon, keratinocytes then produce CXCL9 and 10. These are the chemokines that attract and recruit additional CD8 lymphocytes into the skin, producing more interferon gamma. And these are the cells that are responsible for melanocyte destruction. They release granzyme, other mediators that we think kill the melanocyte. And obviously, when the melanocytes are lost in any given area, you have an area of depigmentation that appears. So how does Opzelura work? Opzelura that we tested in the clinical trial, the Opzelura cream or ruxolitinib in a concentration of 1.5%. Opzelura inhibits JAK1/2, and it's thought to block the interferon gamma JAK-STAT pathway that is so essential given our current data in driving depigmentation, driving the destruction of melanocytes that we see here. So Opzelura or ruxolitinib, the active ingredient, it binds to JAK1 and 2. And so when it binds to JAK1 and 2, STAT can no longer bind to its JAK receptor. It cannot translocate to the nucleus, triggering transcription of interferon gamma and chemokines, driving the destruction process for melanocytes. So I think what we can say is ruxolitinib or Opzelura is effective in putting out the immune fire driving the destruction of melanocytes in vitiligo. And when we put out that fire, we create an environment that is much more favorable for regrowth of melanocytes. So how does that happen? So if you don't have gray hairs in the area, we know that you still have a reservoir of melanoblasts that you see here residing in the bulge and the outer root sheet. And so these melanocytes can mature and migrate out to repigment these the area of depigmentation. And the most common pattern is perifollicular repigmentation. And I think for many of you who treat vitiligo, you've seen that speckle, though that area, the follicular areas of hyperpigmentation or pigmentation coming back into an area of vitiligo. The other pattern, which is a less efficient pattern, but it happens, is marginal repigmentation, where melanocytes migrate in from the borders of lesions, but clearly the perifollicular is the most efficient pattern. So now I want to get into the ruxolitinib data. So the data that was submitted to the FDA for approval was the TRuE-V1, TRuE-V2. These were identically designed phase 3 studies. Patients had to be adolescents or adults, 12 years or older, with non-segmental vitiligo. They had to have at least 0.5% face body surface area, BSA involvement of the face, and 3% or greater on the body, but not to exceed 10% involvement. Patients were not permitted to do phototherapy. And if you had complete leukotrichia with any facial lesion, those patients were excluded. Patients were randomized 2-to-1 for active versus placebo or vehicle. So in the Opzelura group, there were 450, vehicle 224. In the open label extension, after week 24, everyone got Opzelura, and after week 52, there was a 30-day observation period. So primary endpoint was the proportion of patients achieving a 75% improvement in the facial VASI, F-VASI at week 24. Secondary endpoints were F-VASI 90, F-VASI 50, total VASI 50. And let's just talk about what is a VASI score. So the VASI is the standard measure that we now use in many clinical trials for vitiligo. So it's a composite measurement of body surface area, as well as the extent of depigmentation of any area. So it's expressed as a percentage of body surface area, as I said, BSA, multiplied by the degree of depigmentation in the area. And calculation, it does not include lip, scalp, or the ears. And the total VASI, so we calculated a face VASI score, and the total VASI score encompasses the total body areas, face, neck, hands, feet, upper, lower extremities, as well as the trunk, multiplied by the body surface, by the area of depigmentation. And again, a handprint, hold on, I'm going to go back. A handprint was just, a thumb is 0.1%, a hand is 1%, and then we calculate that by the percent depigmentation in areas. So this is our patient demographic and characteristics. The age was comparable for both groups. The majority of our patients were Caucasian. It's interesting that our patients had long-standing disease. The majority were stable. The minority of patients were skin types 5 and 6, and I think this will be addressed in follow-up studies. So this is our F-VASI response over time, and this is pooled data for the TrueV1 and TrueV2, and here you can see at week 24. The F-VASI 75 was 30% for the active group, 10% for the vehicle group, and then when everybody was then treated in the active study, our overall data literally doubled in the frequency, going to 51%. I can't see my number here. Okay, and then for these patients who then were treated with the active drug beginning at 24 weeks, it increased approaching where the active group was at baseline. And this is a patient achieving the F-VASI 75 at week 24. You can see baseline, the extensive areas of depigmentation. At week 12, this patient had an 83% change. And then at week 24, you can see the significant change that she has here, marked improvement. I'm not advancing, Roxanne.
If you click in the middle of the screen to take back control, it should be, there you go.
Okay, perfect, thank you. So I'm gonna go back. Okay, so this is a patient achieving an F-VASI 75 at week 52 with Opzelura. And you see his baseline images. At week 24, he has a 44% change, and at week 52, a 78% change. So marked improvement for this patient. And this is a patient, and this is our data. This is the FAAD 50 responses over time. You can see at week 24, the 52% of the patients achieved at FAAD 50 versus 19% of the vehicle. And this number significantly increased at week 52. And then our group, the group that was treated with vehicle, again, who was treated with open, who then started Opzelura at week 20, at week 24, significantly increased. Now, this is a patient achieving an FAAD 50 at week 24 with Opzelura. You can see baseline, week 12, this patient had a 62% change. And at week 24, there was a marked improvement. And this is a patient achieving an FAAD 50 at week 52 with Opzelura. Roxanne, I want to be able to show my hyperlink, but I can't get to it.
So I think if you collapse your right-hand panel with that little arrow, then you could probably get to it. Let's see. Is that working for you? Dr. Grimes? Oh, we lost Dr. Grimes. So she'll be right back. Dr. Kircik?
Yes, Roxanne.
So Dr. Grimes just logged out. We're getting her to log back in.
Would you like me to take over, or?
Yes, we're trying to get her back in. Maybe there was a issue with her internet.
So we'll take over. I apologize for the technical difficulties, everyone, but I'd like the program to go on. So let's move on. Let's take a look at facial VASI 50 at week 52. As you already heard, the original study was 24 weeks, and then the unlabeled, on the drug course went on from week 24 to 52. Now you can see that the improvement is moving on here all the way from baseline when facial VASI was 0.5, went up to 0.45, about 10% change at week.
Dr. Grimes is back, Dr. Kircik.
Okay, go ahead, Pearl. I was trying to continue here. Please go ahead. I'll disappear.
And Dr. Grimes, if you could turn your camera on. Just by clicking on the gray camera. There you go.
Okay. All right. So this is a patient achieving an FAAD 50 at week 52 with Opzelura. You can see baseline, week 24 and week 52. This patient had an excellent response.
Dr. Grimes?
I'm here.
Okay. Did you want me to move your slides? Would that be easier for you?
Yeah, this is just stuck.
Okay, let me try to move your slides for you. There we go. Just tell me when you want me to move the slide.
Okay. So this is an FAAD 90. The FAAD 90 responses over time. You can see that at week 24, the FAAD 90 was 16% versus the vehicle 2%. Can you click on that for me, Roxanne? I don't know why. Okay. So now if we go to the open label treatment extension, we go from, for the active group, we go from 16% to 31%. And for the group beginning treatment, who was in the vehicle group at week 24, those individuals increased, the F-VASI 90 increased to 14%. Next. And this is a patient, I call this patient one of our poster boys. This patient achieved an F-VASI 90 at week 24 with Opzelura. You can see the extensive depigmentation at baseline. And at week 12, you can see marked repigmentation. And interestingly, this pigment has come in darker than his normal skin. We see this often, it blends in, and you can see the marked improvement that he has at week 24. Next. And this is an adolescent patient achieving an F-VASI 90 at week 52 baseline. Week 24, marked improvement in the peri-oral mid-face, peri-orbital region, and at week 52. Next slide. So this is now, we've been showing you facial VASIs. Let's now look at the total VASI 50 responses over time. So in the pool data, the total VASI 50 at 24 weeks for the two groups was 24% versus 7% for the vehicle. And then if we go to 52 weeks, we had increased from 24% to 51%. And again, the group beginning treatment at week 24, our vehicle group, their total VASI 50 increased to 27%. And I think one of the major take-home messages here is in vitiligo, to optimize outcomes, it takes time. Next slide. So this is a patient achieving a total VASI 50 at week 24 with Opzelura. And you can see the back of the neck at baseline, week 12 and week 24, marked improvement. And this is the patient's leg and knee at baseline, week 12 and week 24. And that patient's baseline total VASI, the score was 3.07. And it had improved, it had decreased to 1.47. So next slide. And this is a patient this is a total VASI at week 52. This is a baseline hand, and that patient had a 65% response by week 52. And you can see improvement on the belly area as well. So a 50% improvement in the VASI score. Next slide. So with that data now, the outcomes data, let's now look at our treatment emergent adverse events. So if we look at Opzelura versus vehicle, the most common treatment emergent adverse events were acne, pruritus, nasopharyngitis, and headache being higher in the Opzelura group versus vehicle. Adverse events that occurred in less than 1% of subjects in the Opzelura group and none of the vehicle group were hypertension, anxiety, some application site discoloration. And it's interesting that if we look at discontinuation rates, they were low, less than 1% of patients in either study discontinued. Next slide. And these are treatment emergent adverse events at week 52, very similar to what we saw at week 24. Obviously, here you see COVID #1, but obviously this study was conducted during our COVID period. But if we go beyond the frequency of COVID, we're seeing the same frequency of adverse events: acne, nasopharyngitis, application site pruritus, and headache. And if we go here, patients who discontinued, Again, less than in the Opzelura group, less than 1%. Patients with serious treatment emergent adverse events, 2.4% here versus 1.6% for the vehicle. Next slide. And this is exposure adjusted incidence rate of select TAEs. And I think this is important because this is a question we're often asked. So what about serious infections? 0.6% for Opzelura, opportunistic 0, tuberculosis 0, 0.4 for herpes zoster, 0 for mortality, 0 for lymphomas, non-melanoma skin cancers, 0.2, other malignancies, 0.6. So I think that hopefully this can reassure you regarding the overall safety profile of this topical modality, despite the fact that it does have a black box label. Next slide. So dosing and administration information. You know, satisfactory patient responses take time, as we know for other topical treatments for vitiligo. If a patient is not achieving any meaningful repigmentation by 24 weeks, the patient should be reevaluated, and you consider combination of alternative approaches. This is a non-steroidal agent that does not cause thinning or atrophy like topical steroids. You can use it long-term around the eyes, the mouth, the external genitalia area. It is not for ophthalmic or intravaginal use. It's applied as a thin layer twice daily. Can be used up to 10% total body surface area, as we used in the clinical trials, and patients should not use more than 60 grams per week. Next slide. And, you know, regarding patient selection and access, helping patients to obtain Opzelura, well, the patients obviously must be 12 years of age or older with non-segmental vitiligo, and it shouldn't be used on more than 10% of the body surface areas. You know, for access or assistance, there's Cover My Meds, copay savings programs. There are also patient assistance programs, and we're still struggling really to get Medicare to cover Opzelura. Next slide. So now I want to end talking about really key safety information for Opzelura. So let's start with serious infections. So patients treated with oral Janus kinase inhibitors for inflammatory conditions are at risk for developing serious infections that can lead to hospitalization. So regarding infections, tuberculosis has been reported, pulmonary as well as extrapulmonary, invasive fungal infections, including cryptococcosis, pneumocystosis, a spectrum of bacterial, viral infections, opportunistic, herpes zoster. So I think you have to be aware of this. If the patient, you should not use Opzelura in any patient who has an active infection. And if a serious infection does develop, then obviously Opzelura should be discontinued. Patients should be monitored, and you have to always consider the risk versus benefits. Serious lower respiratory tract infections were reported in the clinical development of topical ruxolitinib, but we didn't see it in the clinical trials. There were no cases of active tuberculosis reported in the Opzelura trials. Cases of active tuberculosis were reported in clinical trials with the oral Janus kinase inhibitors for treatment of inflammatory conditions. So patients, you should at least have that conversation with patients in having a sense of their status regarding latent or active TB infections. Viral reactivation, including herpes, viral infections, particularly herpes zoster, have been reported in clinical trials. Also, hepatitis B viral load increases with or without associated increases in transaminases have been reported. So Opzelura probably should not be used in patients who have an active hepatitis B or C infection. Next slide. And regarding overall mortality, in a large randomized post-marketing study looking at patients who had rheumatoid arthritis who were 50 years of age or older with at least one cardiovascular risk factor who were treated with an oral JAK versus a TNF blocker, there was a higher rate of all-cause mortality. But again, this is with an oral JAK, not a topical. Same thing if you look at malignancies in that group of RA patients, there was a higher rate of malignancies excluding non-melanoma skin cancers. But again, this is looking at oral data, not our topical studies. The frequency of malignancies is higher if the patients were a past smoker. That provides an additional risk factor. So again, how does this relate to Opzelura? We should just consider the risk versus the benefits and monitor our patients accordingly. Non-melanoma skin cancers, including basal squamous cells, we did see with Opzelura. The incidence was very, very low. So, however, we should screen our patients periodically, or we should do a routine skin check. Next slide. And if we look at major adverse cardiovascular events, again, going back to that same rheumatoid arthritis, older patient population treated with an oral JAK versus a TNF alpha, there was a higher rate of major adverse cardiovascular events, and patients who had a current or past history of smoking were at a higher risk. So we should discontinue Opzelura in patients who are experiencing any signs, symptoms of cardiovascular infarction or stroke. So we should be, I think the take-home message is we really should have a sense of the medical history of the patients where we're prescribing Opzelura. Regarding thromboses, thromboembolic events were observed in the trials with Opzelura. And again, if we go back to that RA group, oral compared, looking at an oral JAK versus a TNF alpha, there was a higher rate of thromboses with the patients treated with the oral JAK compared to TNF alpha blockers. So avoid Opzelura in patients who have any risk of thromboembolic issues. Next slide. So regarding thrombocytopenia, anemia, and neutropenia, these changes were reported in clinical trials with Opzelura. So again, it goes back to screening. Consider the benefits and the risks for individual patients. Know your history of your patients prior to initiating therapy with Opzelura. You can consider performing periodic CBCs for monitoring. Lipid elevations have been reported with treatment with oral ruxolitinib, including elevations in total cholesterol, LDL, and triglycerides. And in summary, if we look at our adverse events, in atopic dermatitis, the most common were nasopharyngitis, diarrhea, bronchitis, ear infections, and in non-segmental vitiligo, greater than 1%, as we mentioned earlier, acne, application site pruritus, nasopharyngitis, headache, and these were uncommon. So I think in the real world, and we're seeing, I think the most common one we're seeing in our real world experience is probably acne. Clearly, I think the benefits substantially outweigh any of the risks that we talked about tonight. If a patient does get pregnant on Opzelura, there is a pregnancy registry. However, patients should, hopefully avoid pregnancy issues. And as far as lactation is concerned, Advise your patients not to breastfeed during treatment with Opzelura for approximately 4 weeks after the last dose of medication. Next slide. So in summary, this medication was officially approved by the FDA in July of 2022, and I remember the day so well. It's the first and only FDA-approved topical JAK inhibitor, specifically for treatment of vitiligo in adults and pediatric patients 12 years and older. In our phase 3 double-blind study, 1 in 3 patients achieved an FAAD 75 at week 24 in the open-label extension. Half of the patients achieved an FAAD 75 by week 52, suggesting that the longer you're on it, the better the response. I think it's important to set realistic expectations with our patients, i.e., it takes time. It's a non-steroidal cream. We don't have to worry about steroid-related side effects. We can use it in sensitive areas. Most common side effect, acne, pruritus, but clearly I think having used this medication in the clinical trials and having an extensive real world experience at this point, I think I can make the very objective statement that the benefits outweigh the risk. Next slide. So I think it really is a welcome addition to our therapeutic armamentarium. Patients living with atopic dermatitis or non-segmental vitiligo can help inspire and inform other people with these conditions. I've done some work with my patients, and I think it is just so informative in sharing and disseminating knowledge. It creates hope. It impacts health and humanity. So I would encourage all of you with patients with vitiligo, have your patients share their stories. The Incyte Dermatology Advocate Network is seeking patients who are willing to share your stories. And here you see, you can learn more about becoming an advocate by calling the number that you see here. So it really is my honor and passion to present this data to you tonight. And I attended World Vitiligo Weekend in Atlanta, and we had 250 patients with vitiligo. And I can only tell you, it was such an emotional and moving weekend. And I've been doing this 40 years plus. And I am as excited, emotional, and passionate about vitiligo today, probably more, I think much more than I was when I began this journey many, many, many years ago. So I really do thank you for your time and your attention tonight. And I'm so sorry for the little hiccup. Thank you, thank you.
So again, if you want to submit questions to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. And if you ever think of a question after the webinar, you can always send it in to info@idefeducationalseries.com. Again, we'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. And please remember to join us on July 25th with Dr. Heather Woolery-Lloyd, when we're going to be discussing mild to moderate atopic dermatitis and skin of color at 7 p.m. Eastern Standard Time. So Dr. Kircik, we do have time for some questions.
Perfect. So I have a couple of questions, and one that came up, the first one, Pearl, it's really a very appropriate question, which is, they say, the studies are 24 weeks and then the open label extended on 52 weeks where we see better results. So how do we handle with this patient where we have a very, very impatient patient population in this country?
Well, I think that the vitiligo patient population is a little bit different. Patients have been told over and over and over, first of all, that there's no treatment. And then we tell them that there is treatment. And I think if we take time out and do a little bit of patient education, and let them know, look, with every tool in the toolbox, there is no quick response. However, if you're a little bit patient and you hang in there, you have an amazing chance of getting 75% or greater repigmentation of your face and neck. We can combine treatments and get significant repigmentation on the body. So Leon, I think it's just about patient education and letting them know it's not going to happen in 2 weeks and it's not going to happen in a month. I mean, you may have good signs, but you have to be in for the long haul.
You know, I totally agree with you, and I'm not well known to spend a lot of time with my patients, but I think vitiligo patients get a little bit hand-holding and more attention just because the lack of the treatment options we had in the past. But now that we have an FDA-approved repigmentation treatment option, I think looking at the studies, certainly it's going to take some time, and I think it's going to require some hand-holding and set up the patient expectations.
And I agree. And if you look at the burden of disease and the emotional trauma and the journey of these patients, for all of my compatriots, colleagues on the call, on the webinar tonight, I would just beg of you just to go that extra mile and just do a tiny bit of hand holding, because it goes so far. And I think you can say, wow, I've made a difference for my patients.
Yeah. So we have a bunch of thank you notes to you for the great presentation, but also we have a couple of really very good questions. One is, do you see a difference in timing of the repigmentation with Opzelura depending upon the patient's duration of disease?
Great question, Leon. I love that question, because in some of the textbooks, and I don't subscribe to this, it hasn't been my experience, but sometimes depending on who you're quoting, it will be stated that if you're going to optimize your chances of repigmentation, you got to get it early, or it's not going to happen. And that just has not been my experience. I treat everybody, I don't care how long you've had it. And interestingly, the beauty of Opzelura of this trial is it validated what I see at the Institute. The mean duration of disease in this study was 13 years. And you see the outcome. So it supports the fact that you can treat patients who have had long-standing disease and still get great responses.
But one thing I think, and I'm not sure, I may be wrong, I have not seen a cutout strata of the patients with duration of disease and their response to the drug. I have not seen that, and I think next time when I see...
Well, no, Leon, they did some correlations, okay?
Okay.
So they looked at age versus repigmentation. They looked at skin type, and I wish we could pull up that slide. It's in the appendix. They looked at duration of disease, and we did not see a statistically significant correlation between duration of disease and repigmentation response.
Thank you. You know what? I did not know that. That's really valuable information. So there is no statistically significant difference. That's great to know. And that gives hope for those patients, right, who have the disease for a long time, that there is an option for them as well.
And I can tell you, I have treated so many patients with long-standing disease who have done well. And and then you can ask, if you have an older age patient, can they repigment? And I've got a poster patient right now. She's in her 80s, and we treated her with Opzelura, and she had a phenomenal response.
Nice. Actually, I have a question that's really appropriate. One of the docs is asking, I too have patients with new onset of vitiligo after age 50. What is the recommended workup for this patient group, including geriatric patients?
Well, my workup for these older patients that I'm seeing with new onset vitiligo, I do the same blood work. I do a CBC, a Compton metabolic. I check their thyroid. I check their vitamin D levels. But in that older group, I really do take a deep dive in their medication history. Because if you ask me what I think there is an environmental trigger that we are missing, because I just have no other explanation for this rash of older patients that I am now seeing with vitiligo.
And this is another good question. Is there any blood work necessary to start the patients on Opzelura or any monitoring?
It's not, if you look at the guidelines, there's no blood work that is necessary. But, you know, keep in mind, I run a pigment institute. And so it's just part of the routine practice for us.
Right. But I don't believe there is anything in the package insert that requires anything, any blood work, either on the initiation or monitoring, correct?
Absolutely correct, Leon. There is no blood work required.
Perfect. And then we have another question that says, what kind of signs do you advise to look for your patients for repigmentation? And when do you give up? 3 months, 6 months, 12 months?
Well, first and foremost, I never give up. Okay. There's always something to use. I mix, I match. I mean, Opzelura is such a welcome addition, but I don't want people to feel that you still can't use topical steroids. You still can't use the calcineurin inhibitors. And they're patients that I will still use those modalities first line. And I let them know that if they haven't been on anything, and I tell them, hey, if you're not responding, I've got other things. Then we still use the prostaglandin analog. So I just keep at it, Leon. Now, okay, so now back to the other part of the question. What do you look for clinically? You know, if you go back to what I showed you in the presentation, i.e. putting out the fire. So Opzelura is going to help us put out the fire. And so the first clinical signs of repigmentation is those follicular macules that appear within the depigmented area. Now, you can see them within the lesion, or if you look closely at the border, which is less common, you will see pigment migrating in from the border. And you know, there's also a third pattern of repigmentation that if you look closely, you can see. And that is there's a cohort, a smaller cohort of patients who will have a residual reservoir of melanocytes within the lesion. And you could have a patient who could get some diffuse darkening, but of these types, certainly the follicular pattern is the most common. The typical time to see it is, I would say, I would say by 2 or 3 months. Okay. If you're not seeing anything by 6 months, then I think it's time to really start manipulating your therapy. No.
Perfect. Perfect. Well, we're there at, 10:30 my time. It's 7:30 on the West Coast. So thank you very much for everyone who hanged in this late, especially on the East Coast, but it was well worth it. It's always a pleasure to have Dr. Grimes on board here and to listen to her wisdom. So I thank you so much, Pearl, for joining us tonight. Roxanne, thank you, and good night, everyone. Make sure you join us for our next program with Dr. Heather Lloyd.
Good night, everybody.
Pleasure, everybody. Good night.
Good night. Bye-bye.